All right, everyone, we will go ahead and get started. Thanks for tuning in for tonight's installment of the National Fellow Online Lecture Series. A few housekeeping topics before we get started. So the next lecture will be next Wednesday, 8:30, same time. It'll be on mass event coverage. Speaker will be Matt Sedgley, and Alfie Olfate will be the moderator. Tonight's talk is going to be a good one. So it's on acute muscle injuries. So we have Ryan Kruse from the University of Iowa, who's an expert in this topic, giving this talk, and then I'm Robbie Bowers from Emory in Atlanta. I'll serve as the moderator. So again, as you hear before all of these talks, the point of these talks is to serve as an adjunct to the educational programming with your fellowship programs. We want to provide fellows with access to a large variety of AMSSM speakers and invited speakers, apart from what you may get in your individual programs, and then also help you to assist in CAQ exam preparation, whether you're a fellow or whether you're going up for research. So just remember to mute your microphone, turn off your video. If you have questions that come up along the course of the talk, just put them in the chat function. I'll ask the questions at the end of the talk. We'll have a Q&A session, and then please complete the evaluation, and you'll put that in the chat as well. So we're always looking for input on topics that you would like to see as part of this series. So if you go onto the AMSSM website, as you see right there, if you go to the education tab, you can then go in and type in topics you would like to see and also speakers you would like to see. So that's always very helpful for the subcommittee to get recommendations as we're putting talks together. So you can do that, or you can use this QR code, and that'll take you straight to the form to provide input. This is just something that's in the weekly e-blast that'll be here for the next few weeks. So Shaban Statuta and I are co-chairs of this year's presidential task force on committee structure. We are asking for feedback from all AMSSM members all the way through. So from trainees to practicing physicians, just about your input and your thoughts on the current committee structure and how easy it is to get involved and those sorts of things. And so that the link to that survey is in the weekly e-blast from last week, from last Thursday that Andy sent. It'll be in the one from this week too. So if you'd be so kind to go in and fill that out just to give us some information and feedback, that would be great. So going back to tonight's talk, so this will be on acute muscle injuries. It's something that all of us are going to see a ton of as practicing sports medicine physicians, and something where, it's always good to be as up to date as possible on diagnosis and management strategies for these acute muscle injuries, because they are so incredibly common in sports medicine. And so we have a friend of mine giving the talk tonight, Ryan Kruse from the University of Iowa. He did his PM&R residency training at Mayo Clinic. He did his fellowship at University of Iowa, and he's been at University of Iowa here for the last several years practicing. He's an expert in orthobiologics and regenerative medicine, one of the foremost experts in musculoskeletal ultrasound. And he, like me, has a very special interest in orthobiologic injections for acute muscle injuries, and I'm sure that'll be part of the talk tonight. So without further ado, I'll hand it over to Ryan.
All right. Well, so thanks again for having me. I'm excited to give this talk. As Robbie mentioned, this topic is a passion of mine, as it is Robbie's. So whenever I get a chance to talk about it, I jump at it. This is going to be a fairly broad, kind of 30,000 foot overview of muscle injuries in general, and then we'll dive into some of the specifics on certain topics, in particular orthobiologics for these injuries. So we will get rolling. A couple disclosures, none of which are overly relevant. So let's just get going. So muscle injuries, like Robbie was mentioning, are highly common. I mean, they happen all the time in sports medicine, and depending on the time of year and what sports you cover, you see these, kind of year round. Right now, for those of us that take care of football athletes, we're inundated with these injuries at this time of the year. Um, Depending on the literature that you look at, these are highly common. Some studies, as high as 6.5 per 1,000 hours played, which, certainly is not nothing. One of the things that's important about these muscle injuries is the recurrence rate. The injury recurrence rate is through the roof. And again, depending on the paper that you look at, I mean, these can be as high as 63%. So, the over the majority of people that have a thigh muscle injury or a muscle injury in general, for the most part, are going to have a recurrent injury, which is, a huge burden on the athlete, the team, the school, the organization, so on and so forth. Across the board, hamstring tends to be the most commonly injured thigh muscle or muscle, I'm sorry, in general for various reasons. And of the thigh muscle injuries that we see, the literature would say that the biceps femoris tends to be the most commonly injured. That really hasn't been my experience. I tend to see more semitendinosus muscle injuries, followed secondly by biceps femoris. But regardless, the literature at this point would say that biceps is probably the most common. So does location of thigh muscle injuries, meaning anatomic location, does that matter? I think it probably does. I would say the literature is fairly mixed regarding whether proximal, middle, or distal third injuries are any worse or more common. What I've seen is that typically the distal injuries, for various reasons, tend to involve a longer return to play than the middle or proximal third injuries. And that's assuming that proximal injuries don't involve a tendon. Once you have tendon involvement, then that really makes this not a muscle problem, it's a tendon problem. We think that the longer return to play with distal injuries is probably multifactorial. One of the theories is that for the most part, these muscles tend to have shorter fascicle lengths distally, which then produces somewhat of an unfavorable length tension curve and producing these muscles to injury. I would say additionally, as it pertains in particular to the semimembranosus and semitendinosus, the distal muscle is a bipennate muscle compared to the proximal parallel or unipennate muscle. Bipennate muscles are larger force generators, a more relied upon portion of the muscle. So when those are injured, those, would, excuse me, portend a slower recovery. So I mentioned impact on return to play. So Jan Ekstrand has published quite a bit on muscle injuries. This is a paper from 2012, I believe, looking at 23 European soccer teams over a 4-year period, and basically looked at correlation between MRI injury grade and time until return to play. And what you can see, so this row here, so grade 0 is essentially imaging negative. Injuries all the way to grade 3. And really, if you look at grade 3, I mean, you're looking at over 2 months in terms of time to return to play, which again is a significant amount of time. If this is a mid-season football athlete, then the rest of their season's done. So pretty significant. These grade 1s and 2s, you're looking at, I don't know, 2.5 to 3 weeks or so, but grade 3, pretty significant time until return to play here. This is a different study from 24 Scott Rodeo's group, looking as a retrospective cohort study of NFL athletes with hamstring muscle injuries from a single season. I think it was 2018 or 2019 or something along those lines. Correlating imaging findings using the BAMIT classification with time lost here. I apologize, this is pretty small, but the time until return to play is a fair bit lower in this study. So if you're looking at the highest grade, so grade 4 injuries, you're looking at about a month here, which is, fairly different than the prior study, but regardless, still a significant amount of time away from sport for these athletes. So what types of muscle injuries are there? So for the most part, there's three main types. So we talk about contusive injuries, which I think behave as a bit of a separate animal. The most common thing that we're going to see are acute strains, which we'll talk about here in a couple minutes. Scar reactivation is something that's real and something that can act like an acute strain and can keep these athletes out. And there are some other injury patterns which are outside the scope of this talk. So let's talk about imaging first. If you look at the imaging modalities for muscle injuries in general, really you're looking at ultrasound versus MRI. I mean, most of us will get X-rays on all these patients just to make sure there's not a proximal avulsion, or if it's a follow-up injury, making sure there's not any, MO or anything. But for the most part, ultrasound and MRI are going to be what you're going to go to here. And if you look at the literature, MRI probably can detect pathology sooner and earlier than ultrasound for various reasons. It can pick up early subtle edema more quickly. And so if you're looking at an athlete that has an injury earlier or within, 2 days or so, ultrasound might not be the best option. There's a pretty high risk of a false negative exam. And so if you are pressured to scan early, MRI probably makes more sense here. But once you get above, 36 to 48 hours or so, ultrasound probably makes a fair bit more sense here. It's portable, it's allows for serial examination, it's lower cost, and you've got real-time answers to your questions here. So I would say ultrasound makes more sense once you're outside that window. And I will say that if you're in a situation where you are pressured to do an ultrasound on these patients within that 24 to 48 hours, and you go ahead and do it, if the exam's normal, I would encourage you just to bring that athlete back in another day or two and repeat the exam. Because the last thing you want is to scan too early, have a negative exam, athlete goes back out and then blows through their hamstring and makes, their injury significantly worse. So use that kind of 36 to 48 hour rule um, to keep yourself safe here. All right, so we'll talk about MRI first. So really the purpose of imaging and classifying these injuries is to be able to prognosticate. And that's the only reason to provide a classification system for these. So at this point, most, if not all, of the muscle classification systems are MRI based. And the three main ones, which we'll talk about here in a couple minutes, are the Munich, the Barcelona, and the British or the BAMIC classification system. So the Munich classification system was the first of those three. And what that does is it separates or divides or classifies injuries into a functional category. So muscle pain with normal imaging and structural, meaning on imaging there are, macroscopic structural changes. And then within those, within the structural injuries, these are then further classified into three grades: minor, moderate, and compete, but it really doesn't, or complete, but it really doesn't take into account the size or the length of the injury. And again, we'll go through this a bit more here in a second. The British classification, the British Athletics Muscle Injury Classification, or BAMIC classification, is classified as A, B, or C, depending on the anatomical location of the injury, and then graded 0 to 4 based on the extent of the injury, which again we'll talk about. The most recent classification system is the Barcelona system, or the MLGR, so mechanism, location, grade, and then whether or not the injury is recurrent. So again, the whole purpose of these classification systems is to provide a way to prognosticate timeline until return to play. So Munich, like I mentioned, is first divided into indirect versus direct. Direct is exactly as it sounds. It's a direct blow to the muscle, whether that be a contusive injury, or I guess if you're covering a hockey game, and a skate hits the thigh, a laceration. But apart from that, these indirect injuries, like I mentioned, are then divided into functional versus structural injuries, and you can see here the different types of muscle injuries that fall into each category. I'm not going to read these here, but this was again the kind of the first MRI-based classification system that was out there. BAMIC is probably what most of us use, whether you're using the MRI-based BAMIC or kind of an ultrasound adaptation to BAMIC. But again, we're looking at grades 0 to 4, and then with 0 being normal imaging, and then the grades 1 through 4 are further classified based on where in the muscle the injury is. So a grade A injury is going to be a very peripheral muscle injury involving the periphery of the muscle or the myofascial region. A grade B is going to be essentially an intramuscular region or injury. So the vast majority of the injuries that you're going to see are going to be grade B. And then grade C injuries are muscle injuries that then include a tendinous component. So think of like rectus femoris involving the central tendon, which I would probably argue once you get into a grade C injury and you have tendon involvement, this is going to behave more like a tendon problem than a muscle problem. But regardless, that's how the this classification system works. I'm not going to go through and read all this, one, because I don't want to, and two, that's going to be quite boring. But we're looking at certain factors on imaging to help us determine if this is a, a one versus a two versus a three versus a four. And some of the important things that we're looking at, one is the cross-sectional area, the amount of cross-sectional area that has abnormal signal or abnormal appearance on MRI or ultrasound for that matter. You're also looking at the cranial caudal length of the injury, so not just how much of the cross section of the muscle involved, but what the proximal and distal extent is. And again, this is the grade three and grade four, which we're not going to read. Um, Barcelona. So this, like I mentioned, is the newest of the three. The other term or the other name for it is the MLGR classification. I apologize if this is small. It is to my eyes. So basically what you're looking at here, so mechanism, whether it's a direct or an indirect injury, the location, you guys can read this, the grading, there's further class or clarification of how to grade these down here. And then whether or not these are recurrent injuries, and you take all this into account and create, overall score for the muscle, which again is supposed to predict and prognosticate. Okay, so that's MRI. So let's move on to ultrasounds. We'll talk about ultrasound and then I will show some pictures. So I mentioned the timeline here. So 36, 48 hours, that's the earliest that you should really be considering for the most part, scanning these because of the high risk of a false negative exam. So what are we looking for on ultrasound? We're looking for the presence of edema. We're looking for hyperemia. Excuse me. We're looking for tears, fiber disruption. If you're at an aponeurotic interface or adjacent to a tendon, you're looking for fiber disinsertion from those regions, hematoma. And then one of the nice things about ultrasound here, as everybody knows, is ultrasound's dynamic. And so we can watch these athletes contract their muscle and see what the muscle does. See if it's a smooth kinetic contraction or if the muscle kind of balls up on itself in a dyskinetic manner, which would imply poor neuromuscular control. So ultrasound gives us that ability. And then we'll talk about muscle anisotropy because historically we really focus on anisotropy for tendons, but it does exist in muscles as well. And it can give you false information if you're not careful to pick it up. Okay, so low grade injury here. So this is a semi-T muscle, obviously in short axis here and long axis here. And so what you're looking for, so low grade edema within a muscle is going to essentially initially appear as hyperechoic regions throughout the muscle. So the reason it's hyperechoic, without going way too far in the weeds here, so even when you have muscle edema, you're going to have some degree of micro trauma, micro tearing, micro bleeding, micro hemorrhage. And by the time you scan this, that blood is going to somewhat start to coagulate. And because it starts to coagulate, in addition to the architecture of the muscle, that's going to provide more of a hyperechoic appearance. If this were just muscle anisotropy, which I think I have a cine or a video next. So muscle anisotropy, obviously, as you tilt your transducer, the entire muscle, the appearance of the entire muscle will change depending on the orientation of your transducer. When you have true muscle edema, it's very patchy or fluffy or cloud-like. So you can see here, within the central region of the muscle here, you have this hyperechoic region. Over here, you've got a relatively hypoechoic region of muscle. Down here, hypoechoic region of muscle. So again, it's fairly heterogeneous, not homogeneous. So that is one way that you can differentiate anisotropy versus true edema. All right, I hope this plays and doesn't crash. There we go. So when you tilt the transducer here, so you see nice bright muscle, and really the entire muscle becomes relatively hypoechoic. So hypoechoic, hyperechoic, hypoechoic, hyperechoic. So homogeneous contrast and compare that to the fairly patchy hyperechoic regions here. So muscle edema versus normal anisotropy. All right, this is a bit of a more significant injury. So this is probably a mild to moderate long head biceps injury. So we've got lateral to left, medial to the right, semi T muscle here. You know, more often than not, when I see these injuries, hamstring muscle injuries, we were talking about this earlier today with one of our fellows, that oftentimes falls right on this aponeurotic interface between semitendinosus and long head biceps. So this is a very common region of injury. So you see all this muscle disorganization, this hyperechoic region here. So that's muscle edema here. No large defect, no large fiber disruption, no hematoma, but this is somewhat progressing along the spectrum there. These are easy to pick up. So when you have frank fiber disruption, you have a hematoma, you have a big black hole in the muscle. So pretty easy here. These are fairly hard to miss. I would say if somebody has a large defect in their muscle, I know I mentioned that 36 to 48 hour rule. If somebody has a big defect like this, you're probably gonna pick that up. If you scan too early, that's not at all me saying that you should still scan that early. I think you should still wait. But if you do scan early, something big and bad like this is going to show up. This is just another, kind of moderate grade muscle injury. So we've got normal echo texture of G max here. This is semitendinosus, muscle, sciatic nerve, and short axis. So again, all of this hyperechoic heterogeneity, disruption of the normal muscle architecture here, and you can also appreciate it quite nicely in long axis here. Okay, so what about scar reactivation? So this can sometimes be challenging to differentiate from an acute strain on an athlete. If it's an athlete that you don't have a history on or you've never scanned before, maybe they say, I don't know if I've had a hamstring injury in the past. But what can happen is if in some individuals, these muscles don't heal like normal muscle, and you can get a little scar ball or a little region of fibrosis in there, which you can see in this region here, and a reactivated scar. Essentially, you're just looking for the presence of hyperemia around that scar. So you can see again, hyperechoic fibrosis or fibrotic tissue here. And you throw on Doppler, you do see some flow. So if they have a new injury and they have pain in this region, and you look with ultrasound, you see this, that would be consistent with a reactivated scar. Okay, so standard treatments here, we'll go through, well, we're not going to talk about rest and compression, but we'll talk about the rest of these things, and I'll spend the most time here on rehab and injections because those are interesting. So rehab is critical. It's absolutely critical. If you don't rehab a muscle injury or really any soft tissue injury for that matter, the likelihood that these folks get back at least to their pre-injury level of activity is pretty darn low. So I am a huge proponent of rehab. All my muscle injury patients, athletes have to undergo a course of rehab. Otherwise, it's just the likelihood that they get better is pretty low. So this is just a general rehab guideline that we use. And generally speaking, obviously the goal is to promote appropriate muscle healing and remodeling while minimizing scar formation. In those of us who are older and not elite level athletes, having a little scar ball in your muscle probably doesn't matter. But I can tell you that any elite athlete or collegiate athlete or high school athlete that is very in tune with their body, if they get a little scar ball in there, they're most certainly going to notice it. And that changes things for you and makes things a bit challenging. So three, I don't know if you guys can see it. I can see if these yellow lines. I don't know what those are coming from. Anyways, so three primary stages here. So stage one is really just protection and reducing pain and reducing scar formation. We allow early pain-free range of motion throughout a pain-free arc. We also focus on lumbopelvic stabilization and restoration of neuromuscular control. And you really want to focus and pay particular attention to correction of any sort of modifiable risk factors within the kinetic chain, hence why I mentioned the lumbopelvic region. Once you progress through that, stage two, you essentially increase the intensity. Stage two is when you start to initiate eccentric loading, and then stage three is progression to sport-specific activities. We do have a protocol. I'm happy to share that if anybody wants. Just feel free to email me after. All right, injections. So we'll move quickly through a couple of these, and we'll spend a bit more time on some of the others here. So if you look at all the injection options that in theory can be used for muscle injuries, this is the primary list here. So TPIs or trigger point injections, NSAIDs, steroids, biologics, and there's some of these other injections that are out there that I'll be honest, I'm not overly familiar with. This top one is some combination of anti-inflammatory substances like arnica and echinacea and whatnot. This bottom injection or this bottom substance here, it's a deproteinized bovine hemoderivative that's especially supposed to increase oxygen uptake into cells and promote muscle healing. Obviously, these aren't available in the US, but they are things that are out there. All right, trigger point injections. I'll be honest, for acute muscle injuries, really have, in my opinion, have no role. There's no literature on them for acute muscle injuries. Really, the primary literature is on folks that have, non-specific myofascial trigger pain or trigger points and whatnot. So really no convincing reason to use them for muscle injuries, at least based on the literature. The idea behind it for muscle injuries is sodium channel blockage to, in theory, decrease muscle fibrosis and improve healing. Again, the literature is not really there. And could this medication, those medications be harmful? Maybe we'll talk about that in a couple minutes. NSAIDs. So historically, many of us have thought that NSAIDs could negatively impact muscle healing. Maybe that's true, maybe that's not. This top study here is from 2019 in JBJS, looking at 44 studies that looked at the impact of NSAIDs on soft tissue healing, so not just muscle healing, but soft tissue healing. Bottom line here, the evidence is fairly limited. What they did see is that some of the studies showed that selective COX-2 inhibitors did impact soft tissue healing, whereas non-selective COX-2 inhibitors really didn't have a negative impact. So take that as you will. Looking at this bottom right study, this is a review from 2017, AJSM, looking at NSAIDs specifically for acute muscle injury. And they found a small to moderately significant effect of NSAIDs on reducing muscle soreness, strength loss, and CK levels. So maybe not overly harmful. I would say bottom line here, jury's still out. Probably safe and relatively harmless, but probably not a great monotherapy for muscle injuries. All right, what about steroids? Really, this is the only major paper that's out there, and it's quite old. Regardless, this was a single NFL team over the course of 13 years, 431 athletes with hamstring injuries ranging from grade 1 to grade 3. And what they found was that the return to play post-steroid injection for an acute muscle injury was just over 7 days. Um, no complications from the injection. The re-injury rate, we don't really know. It didn't really mention what that was over the course of the year. So that's quick. That's very quick. I would encourage you guys to read the paper, and you can certainly make your own conclusions. But based on this would say that steroids can potentially get folks back pretty quick. I don't know that this is really commonly done all that much anymore, but just something to mention. Okay, what about PRP? So historically, this has been the primary biologic treatment for muscles, and really does have the largest body of clinical evidence. But what I'll say is that the efficacy of PRP for the treatment of muscle injuries is fairly heterogeneous and fairly inconsistent. So we know that platelets play a role in soft tissue healing, but is their role in soft tissue healing the same for different types of soft tissue? In other words, is their role on the repair process and healing process for a tendon the same as a muscle or the same as a ligament? And I would argue no. And why is that? We'll talk about that in a second here. So not a ton of studies out there. There are about six RCTs, most of them looking at the lower limb. Hamstring muscle is the most common. This top left paper here, this is a RCT, 28 patients with acute hamstring muscle injuries that were randomized to physical therapy or physical therapy plus a PRP injection. Primary outcome being time until return to play. What they found was that the PRP group did return significantly faster compared to the control or the PT alone group. The PRP group returned, just under 3 weeks, so 26 days, excuse me, days or so, versus the the PRP group, 26 days, the PT alone group, about 42 or 43 days. So fairly significantly faster with PRP compared to control. The middle study here is a retrospective review comparing patients with hamstring muscle injuries, same deal, treated conservatively, to those treated with PRP. PRP group returned more quickly, 23 and a half days compared to the control group at 32 or 33 days, so just over a week more quickly. This bottom study here, so this Hamilton paper was essentially a three-arm randomized controlled trial, muscle and hamstring muscle injuries, randomized to PRP alone, PPP alone, and rehab 90 professional athletes. And what that study showed is that there was no significant difference in time until return to play between the three groups. If you really dig through that paper and look at some of the specifics, none of the injections were done with any sort of image guidance. So, could that certainly play a role in why we didn't see a difference potentially? But regardless, that paper would say no difference in either of the two biologics, PRP, PPP, compared to control. So I would say based on the PRP literature, jury is probably still out. Um, but maybe not if you step back and dive into some of the basic science. I think if you dive into the basic science, which we'll talk about here in a second, then it makes sense why the results for PRP are fairly inconsistent and not overly convincing, and probably maybe not the best option here. Again, we'll come back to that. All right, so not everything that you plunk into a muscle with a needle is probably good. So this is just a paper that came out just over a decade ago, looking at the myotoxicity of various injectates, including 44 studies, and they basically did little biopsies and looked at the histological changes of the muscle after these injections. So they looked at steroid, NSAIDs, PRP, and then some of those more novel injections that I mentioned, like Traumeel. What they found was that there's moderately strong evidence that NSAIDs, intramuscular NSAIDs, with the exception of meloxicam, are myotoxic. Fairly unclear whether or not PRP is myotoxic. The evidence from the literature is somewhat conflicting. Interestingly, it was found that steroid was not myotoxic, although there was only one study included. but it was synergistically myotoxic when it was combined with a myotoxic local anesthetic like bupivacaine. So that one study, steroid, probably not myotoxic, injected with a anesthetic, probably myotoxic. But again, that's a single study. Okay, so where does that leave us now? So let's talk about PPP, or platelet poor plasma. So much of the literature is rooted in basic science, which is important, and we'll talk about that in a second. But there is currently a limited, but most certainly growing body of clinical evidence in support of the use of PPP for muscle injuries, and we'll run through a number of those here in a second. And what I really think one of the important points to make here is considering and thinking about the differences between PRP and PPP in terms of what makes those two substances up. So naturally, the biggest player here, the biggest difference here are going to be platelets, right? One is platelet rich, one is platelet poor. So platelets are significantly different between the two, but there are certain growth factors and cytokines that also differ a fair bit between the two. Probably the most important two are myostatin and TGF beta 1. Those have been shown to promote muscle fibrosis, as well as push cells down the proliferation versus the differentiation pathway, which we'll talk about here in a second. Um, I guess we'll talk about it now. So when we're looking at PRP versus PPP, I mentioned the presence, or relative presence versus relative absence of platelets is really a key here. But the presence or absence of platelets most importantly affect this idea of differentiation versus proliferation. And if you can take away one thing from this section on PPP for muscle injuries, it's the idea of differentiation versus proliferation. So what do I mean by that? PRP tends to induce myoblasts, so immature muscle cells, tends to induce myoblast proliferation. So all these little myoblasts, when you have muscle injury, they kind of come out of their homes, they go to the area of injury, they see platelets and these growth factors, and those induce myoblasts to create more myoblasts. Um, However, we don't know if those myoblasts then further differentiate into functional muscle cells, myocytes, or not. And if you have kind of uncontrolled proliferation of myoblasts, that predisposes you to fibrosis. And so it's the idea of proliferation that would explain why PRP oftentimes can induce muscle fibrosis when it's used for the treatment of muscle injuries. Compare and contrast proliferation to differentiation. So in the presence of PPP and the respective growth factors and cytokines, those little myoblasts that are hanging out are then told, hey, it's time for you to grow up and turn into the adult version of yourself and become myocytes and functional muscle cells. So those immature muscle cells become functional muscle cells in the presence of PPP and the associated growth factors and cytokines, versus for the most part in the presence of platelets and those growth factors and cytokines, the myoblasts are prone to scarring. So that's the takeaway here. That's the major difference between these two injections, and that's the major reason why, which we'll talk about in a second, why we're seeing fairly remarkable results in terms of return to play when using PPP. So this was the first clinical study done by Jason Dragoo in the literature. This is back in 2021, so really not that long ago. And this was my first introduction to PPP. I had a lot of all sport athletes that were having a lot of muscle injuries. And over the prior couple of years, I was not having a lot of luck with PRP. I just couldn't predict who was going to get better. And a lot of them didn't get better, or they had recurrent injury. And so this came up and really introduced me to the use of platelet poor plasma. This is an athlete. This is a collegiate football player, acute grade 2 rectus femoris injury, failed early conservative treatment, including hematoma aspiration. subsequently underwent a PPP injection, about 10 mLs of PPP, at 4 different sites within the muscle. This athlete was then allowed or was able to return to play 2 months after, excuse me, after the initial evaluation and 1 month after PPP. So again, it's a case report, but seems, fairly promising. And so after, reading this, I figured, well, if Jason Dragoo says it works, it probably does. So let's try it. And we did. So this was a 23-year-old Division One starting quarterback who had a bad deal problem. So he avulsed off his rectus femoris. Very inconveniently early in the season. So what you can see here, so you've got the rectus femoris muscle here in long axis. You got proximal to the left, distal to the right. So you've got this retracted muscle here. You've got large, somewhat complex hematoma here with the vastus intermedius underneath. I don't know if it's showing up here, but you've got in this EFOV view here, you've got the retracted rectus femoris muscle. So this is a bad deal. We ultimately injected him, which I'm happy to talk about some other time, twice with PPP at 1 week intervals. We put in 9 mLs the first time, 7 mLs the second time, again a week apart. Um, he was able to get back in 17 days post PPP, which ended up being 19 days post injury. So fairly remarkable return to play timeline for somebody who essentially blew through their rectus muscle. And so then our question here was, a lot of these athletes can just gut it out, right, and just push through. And we don't really know what's actually happening at the tissue level. Are they healing? Are they not? Did us putting this PPP stuff in there really do anything? We thought so. So we saw him back. We repeated the ultrasound, and I think this really tells the story here. So again, you can look at this first image here, this retracted muscle here with this large hematoma. Now you can see essentially normal muscle tissue here. So here's rectus femoris, again, proximal left, distal right, extending all the way down to his quad tendon here. And I would argue this is pretty darn normal looking muscle. So pretty remarkable here. Not only clinically did he get better, but now we've got, structural evidence that there truly was healing. So all right, so it worked in one person in a quad. What about hamstrings? So this was a cohort study of 20 collegiate football athletes, all with grade 3 hamstring muscle injuries. Like I mentioned, I most commonly see semitendinosus muscles injuries. So 60% of these folks had semi-T injuries. And if you look at actually, it's on a different slide here. If you look at the chart, which I'll show here in a second, so these folks were able to get back in just under a month. So again, grade 3 injuries in under a month. Pretty darn quick, but I think equally as important here is this. So I mentioned in one of the first slides that the injury recurrence rate can be as high as 63%. If you look at these 20 athletes, there was no recurrent injury within a year. So again, that's a pretty big deal here. The other thing to point out, which is interesting, so most everybody that's done PRP on a patient has seen, the post PRP flare, right? So some people are very, very sore and very, very unhappy with you after PRP. But in my experience, and I think Robbie would agree with this, most people are not overly sore after. Oh, there we go. How do I get rid of that? Look at that. All right. I didn't realize I was drawing over here. So people aren't overly sore post PPP, and you can see here the pre-PPP VAS here just under 5. And 24 hours after, it's essentially the same. So 4.8 to 4.4. So they really didn't have any increase in soreness afterwards, which I think is part of the reason why these folks are allowed to get back so quickly. So that was our second paper that we put out. Let me get over here, sorry. All right, so now we saw evidence. We saw one kiddo that got better with his quad. We saw 20 kiddos that got better with hamstring injuries. So what about the quad with a higher sample size? This is unpublished data, so please don't share this. It's been submitted currently under review. So this is 37 consecutive patients across the spectrum of level of eliteness, if I don't even know if that's a word, with acute quad muscle injuries. And what we saw here, so 73% had rectus femoris involvement, 51.4% had involvement of the middle third of their muscle, and the majority of these were BAMIC grade threes. About 48% were grade threes. And what we saw here is that these folks, on average, these grade three injuries, on average, got back at 37 days, which is a bit slower than the hamstring data that I showed previously, but still pretty darn quick. And again, you can see the VAS change pre to post procedure is essentially negligible. All right, I'm going to go a bit more quickly here. So, when you start talking about PPP, a lot of folks that have done PRP historically, we want to compare the two, right? Like now we've got two options. How do they compare? So this we put out a couple of years ago. So it was 100 patients with acute thigh muscle injuries, and this was all thigh muscle injuries, not just hamstring quad. We included adductors also. So acute thigh muscle injuries. This is a non-randomized study. So after discussion with patients and educating them, we allowed them to decide with our recommendations if they wanted to undergo PRP versus PPP. We then looked at return to play, post-procedure pain, and recurrent injury. So what you can see here, if you look at all comers, so we've got PRP on the right column, PPP on the left. And so for all grades of injuries, on average, the PRP group got back in about 47, almost 48 days compared to 28 in the PPP group. So that is statistically significantly faster in the PPP group compared to PRP group. If you look at the VAS here, so this is pre in the PPP and pre in the PRP, compared to 24 hours post, there was a significant difference between the two. So the PRP group was more sore compared to the PPP group, which is consistent with what I said previously. If you break this down by injury grade, it really becomes more evident the difference here. So, you're looking at essentially half the time, relatively speaking, half the time until return to play in the PPP group compared to the PRP group. So that's a fairly significant change. Now, again, this is a non-randomized study. It has its limitations, but I think this at least provides some groundwork for future studies to, either confirm or refute this. Robbie and his group put this out, I think it was last year or a couple of years ago, which is an excellent overview of PRP and PPP for muscle injuries. Really a great dive into literature, as well as a couple case reports of Robbie's own patients. So I would encourage everybody to take a look at this and read this. It's a great reference to have. So return to play. I think closing up here, which we're close to time, is really dependent on obviously symptoms and progression through an appropriate rehab program. Like I mentioned in a prior slide, we have those stages that I mentioned. We have certain criteria you have to pass to progress through. We're really looking for symmetric strength and range of motion without any symptoms. I mentioned previously the high risk of recurrent injury here. There's various reasons why I think that happens, whether that be the treatment that was chosen for that athlete, the type of treatment. But I do strongly believe that they're oftentimes re-injured because they go back too soon. These athletes feel better before the muscle is actually ready to do the high level stuff that they want it to do. And if they're pushing it too fast, obviously that predisposes them to recurrent injury. I'm a big proponent of serial ultrasound examinations for muscle injury and for allowance of return to play. So what we'll typically do is once an athlete gets to about 80% speed and power, I liked objective data, so Nordboard is great. Speed or power without pain. We then bring him back into clinic. We repeat the ultrasound. We look for certain criteria to say whether or not muscle has healed versus muscle is completed healing versus muscle is still healing or has ongoing healing. Some of the things we look for if they had a hematoma previously, we want that to be resolved. We want there to be relative absence of hyperemia in the muscle, which I tend to have seen that that's the last to resolve. Um, and then we mentioned the dynamic nature of ultrasound. We want to see kinetic motion of the muscle. If these athletes can't control their muscle contraction and they go out and, are sprinting at max speed, if they can't control their muscle, then that predisposes them to injury. So look for those things. If we can check all three boxes, then I allow them to go back over the course of 5 to 7 days or progress to 100 over 5 to 7 days. If generally speaking, if the parameters that I mentioned are not met, if we still see a hematoma or if contraction is fairly dyskinetic, then we hold them for another 5 to 7 days at 80% and then repeat the ultrasound at that point. All right. So, in summary, like I mentioned, muscle injuries are ubiquitous. If you're practicing any sort of sports medicine, you're going to see hundreds of muscle injuries, if not thousands, in your career. They're a pain in the butt. A lot of athletes lose a lot of time from their sport with these injuries. I think imaging is important for grading and prognostication, and I think probably most importantly, it's important for guiding return to play, specifically as it pertains to ultrasound. There are myriad injection options that are out there with various pros and cons. Um, I have very strong opinions that PPP at this point is the one injectate that makes the most sense by far for folks with acute muscle injuries as it pertains to speed until time until return to play, as well as recurrent injury rate. All right, that is all I have for you guys. Thoughts, questions?
Cool. Thanks, Ryan. That's great. Okay, so we got a few questions that I will go through. But I will, you'd mentioned a couple things. Yeah, in my experience in doing, a pretty good number of these PPP injections for acute muscle injuries, I agree with you that they don't have the soreness afterwards, and we actually have had athletes and athletic training staffs comment on their symptoms resolving faster after the PPP injection than they would have if they had had nothing done and just done rehab and kind of modalities alone. They kind of feel better faster. Certainly have some soreness just from the injection alone, just the needle going into the muscle, but then they tend to have soreness maybe that day, and then things will resolve faster than they normally would. Has been the feedback that I've had from athletes. And then conversely, from some of the things, I don't know what the mechanism for this is. Some of the things that you had said in tracking ultrasound, and I've used your protocol from an ultrasound standpoint, the 80%, as you've told me that, and scanning them at 80% and making sure things look pretty good at that point to allow them to go to 100. There is a paper that was published in the past year that said that they took I forget how many athletes it was. I can probably look here. I had the paper pulled up. How many athletes did they have in this study? So they had 58 athletes, and they looked at 3T MRI at return to play of those athletes. Basically, they returned them to play as they normally would, and more often than not, they still saw some abnormalities on 3T MRI. Obviously, 3T MRI is a very high powered MRI, so as far as following MRI to complete healing before return to play, that may not be something that is necessary to do in making some clinical decisions without necessarily full healing on a high powered MRI to make your return to play decision. So those are just a couple thoughts that I had as we kind of went through the talk. Now let me go back to some of these questions that we had. All right. So if anyone needs the link to the member feedback form that I mentioned beforehand, Andy put that in the chat. So John asked really a question about your thoughts on BFR, and so I'd kind of broaden his question to: do you have any thoughts on BFR, and then also BFR after a biologic injection for an acute muscle injury?
Yeah, I think it's fine. I don't think it's a bad idea at all. I mean, it allows you to, do submaximal load, across the muscle while still gaining, maximum, strengthening of that muscle, while somewhat protecting it. So I think it makes sense. I don't know that it's necessary. I mean, I don't routinely use it really at all for my athletes. So there's some physical therapists that I'll refer these athletes back to that routinely use it. And again, I think those athletes do fine. And again, maybe they tolerate the load better as they progress because of what BFR does. But I don't know. I don't really have strong opinions on it. I don't think it's necessary. I think if it's there and you have access to it and you want to use it, fine. But I don't think it's needed.
Yeah, I agree. I think there's evolving data for BFR, but I can't say I'm a BFR expert or that it's necessary in any certain situations, and others that may be experts on the topic may have a different answer. Um, okay, so Jill asks, I know my answer to this question, I know you probably have a similar answer. Do you ever aspirate the hematoma prior to a PPP injection?
Always.
Always.
Always. Yeah, I think the key here, so once you aspirate, for the most part, so if you have a big defect in the muscle and the hematoma is taking up space, and when you aspirate it, you're going to get relative opposition of the torn fiber ends, and the thing to think about and not do is when you inject your PPP into there is to not blow that area right back up. Now certainly you're putting volume in there, and you're probably going to get some displacement there, but the key here is not to fill it back up with as much fluid as there was in the hematoma, because you want to try to have those tissues oppose as much as possible. But the answer to your question, hematoma, 100%, even if it's a very small hematoma, I'm going to be in there with a needle anyways. I'm going to try and pull it out.
Yep. If there's fluid to pull out, pull it out.
And I think the nice
Um,
thing too with the PPP is, if this is more of a chronic, or we'll say subacute or less acute injury, and that hematoma becomes thick and more viscous, when you run the whole blood through whatever system you use, you're going to have way more PPP than you need. And so you can use some of that extra PPP to essentially lavage the hematoma, which can make it less viscous and easier to aspirate. So don't hesitate to do that if you have trouble getting it out.
yep. Um, Okay, George, one of our fellows, wants to ask, what's your indicator to move forward with a repeat injection?
Yeah, that's a good question. I don't do it very often, to be honest with you. I think the times where I will do it is if somebody's progressing through and then slides backwards or has a recurrent injury or acutely gets worse, and we rescan the muscle and it still looks either as bad as it did or looks worse, I'll repeat the injection at that point. The other times that I will consider repeat, which again is not common at all, again, outside of a recurrent injury, is if I get somebody back at, they're 80% or so, and I guess there's two other indications. If they're 80% or so and they try to progress back to 100, and for whatever reason they're just stuck week after week after week, they can't get past 80% because of symptoms, then I'll consider repeating it. And then lastly, if somebody is falling just way outside those numbers that I gave you in terms of estimated return to play, if they are just taking forever and not getting back, and we can't really figure out is it a rehab problem that's keeping them out, or whatever, if there isn't some other variable that's contributing to their prolonged return to play, then I will consider repeating it. But I don't know, Robbie, if you do anything else, I just haven't really needed to repeat it any sooner.
Yeah, I can't remember the last one I had to do a repeat injection. Not to say this is some panacea injection, but they work well, and I have not considered a repeat unless they have a re-injury. So that's kind of basically if they re-injure, then we'll consider repeat. Otherwise, they do pretty well in my experience. All right, so Catherine asks, at what platelet concentration, and this, there may be an answer to this, or may not be, at what platelet concentration are you considering an injectate truly PPP, comparing to a relatively low concentration PRP system like some of the ones we see in the literature?
Yeah, I mean, I think the most basic answer is if your platelet concentration is below baseline, then that's technically PPP. And even at these low level, low concentration PRP systems, even if it's 1.1x, right, that's still a super physiologic concentration of platelets. That still by definition is PRP. So to answer the question, I would consider any PPP product with a platelet concentration subphysiologic as PPP. We try and get the number down as low as we can. And what's interesting, if you run your PPP through a cell counter, there are still a fair number of platelets that end up in the PPP, and even on the order of like hundreds of thousands of platelets, which is not nothing. Um, but I think there's some threshold number over which that's the action of platelets takes over and produces that proliferation state, like I mentioned. I don't think we know, well, not I don't think, we don't know what that number is just yet, but I do suspect there's probably some relatively magic number by which we should stay below.
Okay. Um, yeah, agree. Subphysiologic. Two more questions. So there's one from Alex and then one that I'll ask. So and mine won't be necessarily related to biologics. So when using a PRP or a PPP system with a separation tube, would you rather use PPP from the uppermost layer or from the portion just above the buffy coat?
Yeah, so the former, right? So if you think about where when you're creating PRP or when you're creating PRP, where do most of the platelets live? And we think 80% is going to live, obviously within the buffy coat, and then within a mil or two on either side. So a mil dip into the RBCs and a mil into the plasma. So the closer that you get to the buffy coat, the more likely you're going to pull more platelets into the PPP because that's where they live. So I would say as far away from if you're using that type of system, staying as far away from, again, if you have measurements on your device from 1 ml above the buffy coat, that probably keeps you safest from pulling in too many platelets.
Yeah. And then lastly, my question will be from this isn't necessarily a rehab talk, but from a rehab protocol. So say you have a hamstring injury and you do an injection or you don't do an injection. Is there a specific rehab protocol that you will prescribe? So whether that is eccentrics, a specific kind of return to run program, or is that something that you kind of stay out of and let the PTs handle?
Yeah, like I was mentioning, I've got a general protocol that I do send. So I showed on the slide, I showed the stages that we talk about, but I do have a somewhat more prescriptive and descriptive protocol that we'll use. I try to not get too involved, honestly, with the rehab portion. Again, I provide my general guidelines, what I would like generally them to do, but physical therapists, athletic trainers, they're clinicians also, right? And they do this more than I do. So I lean pretty heavily on them. And you know, luckily what we've seen is that, as long as we provide that very basic framework, honestly, I haven't had any problems with them pushing too fast or going too slow. They've really done a great job. So general guidelines, but I let them, they're the experts.
Yeah, I totally agree with that. I think when you get to really high level athletes, these rehab protocols and return to play protocols and run progressions are all individualized. There's no cookie cutter um, program that every athlete's going to do. It's going to be based on how they are progressing, and just like Ryan said, they are experts in physical therapy and in the rehabilitation process, just as we're experts on the clinical side. So we let them be experts and not try to step on their toes too much. Is kind of my approach as well. Um, Okay, cool. Well, thanks, Ryan. That was great. Appreciate it. And if anyone else has any other questions, feel free to reach out to us. Otherwise, tune in next week for the mass event coverage talk, and we'll see you later.